हेलो।
हेलो सर।
हेलो, हाँ पल्लवी।
जी सर, कुछ वो टेक्निकल इशू आ गया था, इसलिए फिर मैंने ये दोबारा से क्रिएट किया है।
ओके, सो डॉक्टर दीक्षा और उनको बोल दो कि वो जो लिंक ज्वाइन करें।
It will not give you any negative marks. Okay,
सॉरी,
because then nowhere it is mentioned about any coagulation. It's only on warfarin, the complex and cardiac history.
हेलो, हु इज स्पीकिंग?
Yeah, because then nowhere
हेलो,
हेलो सर, यू कैन स्टार्ट सर।
ओके। सो so we are discussing that ECG part. Okay, then in exam practice, ECG curves are usually used which are likely to influence immediate management. So you will get those ECGs which require some urgent intervention or immediate management. CBA curve station is likely to contain 2 to 4 ECGs. What do you do is the more common question than what is the diagnosis. So usually they ask two questions from one ECG, that what is your diagnosis and what will you do. So basically, or if here they ask only one question, so they may ask what is your diagnosis, or may ask what do you do, or what is your next step, or what management will you do urgently. So during EDIC, all ECG are displayed in a speed of 25 millimeter per second. Recognize myocardial ischemia and link it to the treatment. Conservative versus straight to coronary cath lab. Locate infarct vessels. Link arrhythmias to the treatment. Pacing. Recognize non-cardiac disease on ECG like drugs, QT, prolongation, hypothermia, or some electrolytes. So usually they ask these things. So you can get at least one question from the arrhythmias, one question from the MI, or one question from the pacemaker, or one question from the electrolytes or some QT abnormalities. So there are 3 or 4 ECGs you will get in the exam. Then curve 2 monitors. The curve 2 monitors, it contains arterial line graph, CVP line graph, ICP curve physiology, pattern of disease on these curves, A line, overdamping, underdamping, hypovolemia. In ICP, there is a normal compliance or decreased compliance, autoregulation, and CVP line, tricuspid regurgitation, cardiac tamponade. In IABP, there may be correct settings, late deflation, early deflation, late inflation, early inflation. So there may be timing errors they can give you. In a dialysis graphs, they can ask the basic problems like access line or filter clotting. So they ask these type of things like this typical patterns to recognize on CVP curves, tamponade and tricuspid regurgitation. So they will ask anything from you. In curve 3 ventilator screens, they will ask you what is the can you calculate the compliance resistance or P, pulse pressure volume curve or flow volume curve. Recognize basic pattern of respiratory pathology like ARDS, COPD. Recognize and diagnose asynchrony like trigger asynchrony, flow asynchrony, or some cycling asynchronies. Then recognize leak or secretions. So they can ask these things from the ventilator screen. So basically 3 types of questions can be asked in the curve station. One is ECG, another is the monitors, and third one is the ventilator. So in 10 to 12 question, 3 or 4 question related to ECG, 3 or 4 question related to the monitors, and 3 or 4 question related to the ventilator graphics. So this is the pattern of the station one, which is curves. Second computer-based assessment station is the biochemistry. They will ask you, they will test your ability to interpret laboratory data in clinical context. So less cases than in other stations, because usually because there is a long questions, so you need more time to read these type of questions. So there is a usually 1.5 minute or 90 seconds per case. So usually 8 in 10 to 12 minutes. So time is very crucial issue when you crack these questions biochemistry, because these are the real life cases, and so many data is there. So you need time to read, and then you have to interpret those data and give you a diagnosis and give you a what will you do for that. So all cases are the real life cases arranged with increased difficulty as per judgment of the author, not necessarily the candidate. They will ask you, or they will test the pattern recognition, whether a correct and quick diagnostic algorithm is running in candidate's brain or not. This is a skill, and that can be only be gained by the daily practice. So this line is very important for you, because for biochemistry station, there is some algorithm which should be run in your brain. Otherwise, you will not able to give answer in the biochemistry station. And thus, this algorithm, you can say the pattern recognition. So whenever they will you give you something like that hypocalcemia, so there are two, three things should be come in your mind. This may be a case of refeeding syndrome, or this may be the case of some tumor lysis syndrome, or rhabdomyolysis. So then you will see whether it's hyperkalemia or not, whether it's hypomagnesemia or not. So you will think in like way, and then you will able to give the answer. As in every other clinic computer-based assessment, candidate is allowed to skip a difficult slide and go back if time is left in that. So I have already told you that if you find a very difficult question in between, so don't waste too much time on that particular question. Skip that slide and go to the next one. And in the last, if you have enough time to go back to that slide, you can do that. But this is not possible for the CCS part, yani clinical case scenario, but this is possible for the CBA part. Sometimes only few values are displayed, and sometimes a whole array of normal and abnormal results, as it is in the real life. So don't be surprised that in some question there is a very limited data is given to you, and in some cases there is a very large data given to you, whether it's a relevant or not relevant. So be ready for that. Don't expect they will give you only relevant data or a limited data. They can give you a very large data, like in the real life scenario. Because when you see the patient, you have all the lab reports in front of you. There is a CBC, LFT, KFT, culture reports, or so many blood reports. So you have to analyze all those information and make a diagnosis what you are dealing. Then clinical vignette would guide you what to look at. Typically, this CBA is a mixture of difficult acid-base cases, sodium and water metabolism disorders, underlying disease with a typical biochemical picture. So in the same patient, this is not a simple acid-base case. There must be some electrolyte imbalances also along with the some acid-base disorders. Like in the real life, 1 to 2 cases with hematological diagnosis, one case testing the ability of candidate to interpret the lab data under unusual circumstances. Like ABG in pregnancy is differently interpreted as the ABG of a non-pregnant female or male. During hypothermia, ABG interpretation is different. No, unlike in the normothermia. So for the same test can be differently interpreted in a different circumstance. Both traditional and SI units are displayed and abnormal values are highlighted in the red. So they will give you all the blood values in the traditional units as well as SI units, and they will mark all abnormal values in the red color. So you can very well understand that these are the abnormal values. So basically in the biochemistry station, you have to find out medical disease with some specific pattern. So pattern recognition is very, very important to clear this exam. Otherwise, you will face challenges of the time. So many of the candidates say that the time was less. I have done only 6 or 7 cases, or I have done only, I have attempted only 8 cases. I don't have time. So you will definitely face the challenges with the time because the time is very limited. So you have to make some algorithm in your mind so that you can find out the pattern and pick the answer. Then imaging part. In the imaging part, there is a 10 to 12 slides for the computer-based assessment images, 15 minutes, 12 to 15 minutes for CBA images. So you can get 60 to 90 seconds per slide. And usually 4 to 5 chest x-rays in the imaging section. Question normally asked, what is the abnormality? Like chest x-ray, you can find out the collapse, consolidation, infiltrates, pneumothorax, pleural effusion, pericardial effusion, some cannula position or some tube position, airway compression, cardiac sellout, mediastinal masses. So anything you can get in the exam. Identify abnormalities requiring urgent intervention. A systematic but quick and focused approach is advised. Answer the question. No cheap points will be awarded, like describing a line in a normal position. So if they are not asking line, suppose there is a internal jugular CVP line is there, and you are saying the line is in the normally placed, so you will not get any mark for that. Then in lungs, infiltrative differential diagnosis like alveolar versus interstitial collapse, recognize lobar collapse, whiteout, collapse versus consolidation versus fluid versus post pneumonectomy, cyst or cavity in pleura, pneumothorax, sign of tension pneumothorax, surgical emphysema, deep sulcus sign, pneumomediastinum, flail chest drain, insertion, fluid in thorax, differential diagnosis from lung collapse and infiltrates. In diaphragm, the diaphragmatic palsy, diaphragmatic rupture, pneumoperitoneum versus gastric bubble. In bones, there may be some fracture of the ribs, fracture of the clavicle, missing ribs in a post-pneumonectomy case or post-lobectomy finding. Abdominal x-rays, you can find out the ileus, small bowel, large bowel, distension or ruptured viscous, toxic megacolon, nasojejunal tube position. In CT brain, normal appearance of young and old brain. Sometimes old brain is look like a hydrocephalus. So this is not usually according to the age you have to interpret. This is not the hydrocephalus because there is a cerebral atrophy is there. Raised ICP, the signs herniation, mass effect, midline shift, hemorrhage, traumatic and non-traumatic, subdural, extradural, SAH, interparenchymal, hypertonic versus atypical versus traumatic, large ventricle, whether this is a hydrocephalus or atrophic brain. So you have to identify depending on the age. Ischemia, early versus late sign, embolic versus arterial occlusion, MC infarcts, is it for decompression? Then CT chest, there is a aortic dissection, pulmonary embolism, lung abscess, pneumothorax, fluid in the thorax, mediastinal air, enlarged lymph nodes. So you can find these types of finding in the CT chest image. Ultrasound chest, you can find the signs of pneumothorax, consolidated lung, tamponade, severe RV-LV dysfunction, severe hypovolemia. In CT abdomen and USG abdomen, you can find the perforation, pneumoperitoneum, dead bowel, trauma. hemoperitoneum, contrast extravasation, damage to parenchymatous organ, pancreatitis, hydronephrosis, ultrasound abdomen fluid in trauma, hydronephrosis versus renal cyst, IVC in the assessment of fluid responsiveness, liver ultrasound in jaundice, CBD or intrahepatic dilatation. So you can find these types of things, but usually these things are not a part of EDIC exam, like MRI. Usually they don't ask the MRI. Transcranial Doppler, small vessel angiogram, radionuclide studies, advanced echo like color Doppler or valves. So usually these are not the part of EDIC exam. But this is not a rule. They can ask, but you should not prepare for that. If they will ask these things, then definitely there will be some hints or some requirement of the question. Then only suppose they had given some like brain death patient, so empty salicine or some small vessel angiogram finding they will give you. So those things you will find out in the exam. No need to go for no need to prepare for these topics. If this type of thing is given in the exam, you can very well interpret what they are asking. Okay, so no need not to do practice for MRI or TCD or small vessel angiogram, radionuclide studies or some advanced echo. So this is the final mark sheet for the EDIC 2 exam. In the CCS, some candidate have find 31 out of 54. Passing mark is 29, so result is pass. Suppose in 2A, mark is 20, maximum 30, so passing mark is 16, so pass. Like in CCS 3, marks obtained is 33 and passing mark is 36, so he's failed. But he is pass out of 2, so he is pass. Okay. Like in this stations, CBS, CBA 1, 2 and 3, imaging, curve and biochemistry, he has passed in all the 3 stations. Passing mark is 20, he got 21. Passing mark is 15, he got 18. Passing mark is 14, he got 17. So he has passed all the 3 CBA stations. So final result is pass because he has separately passed in CCS as well as CBA. Okay, so this type of marking is there. So you have to be very careful. Now the recommended reading for clinical case scenarios. So you can read these type of books like Case-Based Review in Critical Care Medicine by Dr. Atul Kulkarni, Patient Challenges in ESICM ACE modules. So you can find ACE modules in your ESICM website, and you have to go in the patient challenges part, which is given in the end of each module. So in the patient challenges, you will practice. And then Irwin Rippe Manual of Intensive Care Medicine. This is very good book, especially for some topics which are difficult or which are routinely asked. You can read some topics from this book. And Washington Manual of Critical Care Medicine. This is also a very good book to read some important topics for the preparation of CCS. Then CBA, computer-based assessment. So there are some OSCE books available, like OSCE in Intensive Care Medicine by Jaya Shankar and Daniel Ons. OSCEs for the final FFICM by Raj Nichani. This is also a book, very good. ECG for Emergency Physician Level 1 by Amal Mattu. So this is very good book for the practice of ECG at the introductory level. Then Chest X-ray Made Easy. This book is for chest X-ray interpretation. Radiology for Anesthesia and Intensive Care by Richard Hopkins. So this is a very good book for X-ray, CT scan, CT chest or CT abdomen, as well as CT brain. Then Examination Intensive Care Medicine by Carol Foote. This is a good book written by 3 or 4 authors. Basically, these are the notes of the critical care. So somebody has put down all the notes in one place. So, but for the exam point of view, this book is important. Data Interpretation in Critical Care Medicine by Bala Venkatesh. This is very good book for especially for the ABG part or some biochemistry part. So for biochemistry and ABG part, this data interpretation book is very important. Then Stewart's acid base approach. So basically, we are not using the Stewart approach, but ESICM people wants that you should try to give answer by the Stewart's approach. So if you are able to understand the Stewart's approach, then it's good. Otherwise, leave it and do whatever we do routinely for calculation of our ABGs. Then Scott Ritchie, this book is very important for ventilator graphics. So identify patient ventilator asynchrony and optimize settings. So this book is very beneficial for that purpose. So all the books written here are very important, and depending on the time and energy, you can read those books. So there are some pictures of those books. Objective Structured Clinical Exam, OSCEs for the final FFICM, and Scott Ritchie book for ventilator graphics, and Data Interpretation Critical Care Medicine by Bala Venkatesh. This is Carol Foot book for examination, intensive care medicine, then radiology for anesthesia and intensive care by Richard Hopkins, and this is Stewart's acid base textbook. There are some online resources are also available, like I have already told you, ESICM website, ACE modules, or you can take subscription from the Crit IQ website or Amal Mattu ECG blog for the advanced ECGs, and Life in the Fast Lane. So if you have any difficulty to understand a topic, you can Google by right name of the topic and the Life in the Fast Lane. So if things are given in the Life in the Fast Lane, then definitely it is very well written, and you will get the enough exam relevant information from this website. Then Mount Sinai Emergency Medicine Ultrasound website for bedside ultrasound and echocardiography. Or in India, there is a critical care eco.com by CMC Villor. So these are two websites, or you can use the Sonosite website also to see the ultrasound and echocardiography videos. Then these are the ACE modules like acute ischemic stroke, and when you go through this module, you will get the patient challenges part in the last. So you can solve those questions and you will get the insight how they ask in the exam. Then I am just showing you a case. This is introductory vignette that a patient involved in road traffic accident, and paramedics arrive at the scene. Patient is combative, smelling heavy alcohol. GCS is low, 13/15. Patient's airways patent, C-spine and fixed collar. This is the vitals, and then patient X-ray is showing the right chest drain inserted because of the high muscular chest wall. Ventral approach are chosen, 2 large bore cannula put, and he's given 1 liter ringer lactate, and then these are the values. So this is the introductory vignette, and they will ask you this type of question. First question is, please summarize the case. So in the summarize the case, you have to tell, let's say, trauma patient, you will get 1 mark. Right pneumothorax, you will get 1 mark. Massive hemorrhage, you will get 1 mark. Intra-abdominal injury, the 1 mark. Otherwise, whatever will you say, you will not get any mark. Okay, so need not to summarize or reading out this vignette. A 22-year-old man is involved in road traffic accident. You need not to say like that. You have to find out this is a road traffic accident, RTA case, number 1. Second thing, right pneumothorax is there. Third thing, hemorrhage, massive hemorrhage or some fractures. So you have to tell these things or only you will get marks when you say these things. Other than these things, you will say any of the line, there is no marks. So you don't know what is written in their iPad, but you have to tell the answer in a way that all the important things will be covered and no other things you should speak. Otherwise, you will waste the time. Then second question, what are the 4 views undertaken with the fast scan? So you will tell the Morrison pouch, perisplenic, pericardial, suprapubic. Then what will be the next appropriate management plan? So transfer the patient to the or operation theater for urgent laparotomy, continue resuscitation with his blood products, CT scan. These are the next management. What are the key principles of damage control resuscitation? So rapid control of surgical bleeding, prevention of hypothermia, hypotensive resuscitation strategies, prevention of acidosis. These are the things you will tell them and then you will get the marks. So nowadays the marks are almost same, 1 1 or 1 2. Earlier there were different type of marking, 1 3 and 5. So the most important thing gets the 5 marks, and the less important is 3 marks, and least important get 1 mark. But nowadays they will give you same number of marks to each and questions. So not a more weightage of answer giving one question to the another. Then vignette 2, he goes to the operation theater where he becomes hemodynamic and stable. After the induction of anesthesia and during surgery, the sigmoid colon has been perforated, then operation done. And these are the ABCs. And what will you, then next vignette question. What are the priorities when this patient arrive on the ICU? So clear handover, you will get 1 mark. Completion of history taking and diagnostics, re-establishment of homeostasis and physiological function, perform a secondary survey or reassessment of the patient, you will get 1 mark. So these types of questions they will ask in a vignette 2. What measures should you institute in this patient to help with coagulopathy, because there are high chances of the triad of death. So there is a hypercoagulability or coagulation abnormalities may be there may be acidosis, and there may be some hypothermia. So there is a death triad. So they want to see whether you know this death triad or not, whether you take care of hypothermia, whether you take care of the coagulopathy or not. Then what other medications could be considered to help control of coagulopathy, like tranexamic acid, factor 7A? What are the risk of massive transfusion of RBC? So hypocalcemia may be there, transfusion reaction, fluid overload, hyperkalemia, dilutional coagulopathy, DIC. So these are the things you expect. So this type vignette will move. Then in vignette 3, patient returned to theater, day 2, abdomen is closed. After return from theater, his left leg is noted to more swollen and tender. Pedal pulses are present. These are the values. So what are the possible differential diagnoses of the swollen left leg? So you will say thromboembolism, compartment syndrome, arterial thromboembolic event, or some cellulitis. So you will say these things. What are the possible causes for the high CK? So rhabdomyolysis may be cause, or some cardiac contusion may be the cause of the high CK. How should this rhabdomyolysis be managed? So in vignette 3, they move on to the rhabdomyolysis. Then patient become anuric for 12 hours. It means now the vignette is moving in the AKI direction. So the first one was the road traffic accident. First vignette, they ask you the road traffic accident. And in the next vignette, they ask the priorities after the surgery, might be coagulopathy or some hypothermia prevention. In 3, there is a thromboembolism or compartment syndrome. In 4 vignette, there is a AKI part. So in one case, the 3 or 4 vignette, and each vignette will have some different type of problem. Suppose patient requiring ECMO, or patient requiring CRRT, or patient requiring some intervention like bilateral ICD, or some pacemaker or something like that. So basically one vignette is one topic. So they will cover around 10 to 12 important critical care medicine topics in these 3 or 4 cases. So be ready for that. In the AKI, they will ask everything. What are the classification of the AKI? How does the regional anticoagulation work? What are the benefits of citrate anticoagulation? How would you manage the citrate toxicity? What factors are the key in the early recovery? So these type of questions they will ask you from the vignette. So be ready for that. In a case, you will get 3 or 4 vignettes. Each vignette is a different topic of the critical care medicine. One topic may be a trauma, one topic from maybe some AKI, one topic from the pulmonary embolism, one topic is rhabdomyolysis, like that. Then imaging part. In imaging, they will give you a question. Obese man extracted from crashed car, had 2 liters of fluids en route to hospital, now desaturates, drowsy, evolving hemiparesis. Question is, what is the likely cause of desaturation? Is this chest X-ray of any help for further management of presumed traumatic brain injury? So you will give the answer like that. The pulmonary edema, fluid overload, anticoagulated. So you will get marks for those answers. Again, they will show you some CT and ask, apart from right side pneumothorax, what are the other significant finding and what is your management option? So they will give blood in the mediastinum, right hemothorax, intercostal drain. These are the things. In the curve section, they have given you some arrhythmias and ask question like describe the ECG, what is your immediate intervention? So this is sinus rhythm changing to VT, ST depression lead 1 and AVL, electrical defibrillation. And next ECG, what is the immediate management? Patient comes to you, 72-year-old male, admitted to emergency department due to acute severe chest pain and mild hypotension. So what is your diagnosis? So this is myocardial infarction. Proceed to cath lab for the STEMI, new LBB or AF or bradycardia. Sorry. So 24-year-old patient, 3 days after traumatic brain injury, repeated CT and so diffuse brain swelling. So these are the ICP curve and MAP, mean arterial pressure curves. So basically they are asking you the auto-regulation of the cerebral perfusion. So auto-regulation is preserved or not. These are the basic ventilatory curves graphics. Patient on the CPAP, nurse is worried about unusual respiratory pattern. So Chinese Stokes breathing, heart failure, central causes. Biochemistry, they give you this 70-year-old man brought to ICU lethargy and visual disturbances. What is the likely diagnosis? So in this case, you have to ketone plus, protein plus plus. What is your likely diagnosis? So it's a multiple myeloma, hyperviscosity syndrome, hypercalcemia, myeloma kidney. So these are the differential diagnosis for this scenario. So this is known as pattern recognition. So you have to find out how will you find out this case, because albumin is low and total protein is too high. So you can see there is a albumin globulin reversal is there. AG ratio, AG ratio reversal is there. So this point is important to understand whether this is a myeloma. Other things are also hinting the same direction. So we will discuss in detail. Homeless man found unconscious. What is your differential diagnosis? So you can say glucose is low and lactate is high. So this may be some ethanol, high osmolar gap. So maybe some methanol poisoning or ethanol poisoning, ethanol glycol poisoning. So this is the way. So basically, you will get 3 types of clinical case scenarios, 3 or 4 in the exam, and 3 CBA stations. One is curve, another is imaging, and third is biochemistry. So you have to pass at least 2 CBA and 2 CCS to clear the exam. Okay. So I have given you information regarding the pattern of exam. and we will go for around 40 classes in this preparatory course, Sunday, Wednesday, and Friday, for so 3 classes per week. So total around 40 classes, in which 20 classes are dedicated for the CBA part and around 20 classes for the CCS part. So you get enough opportunity to learn and discuss the things with the faculty. So we are 4 or 5 faculties in this preparatory course. Other than me, there is a Dr. Nitin Jain or Dr. Munish Chauhan or Dr. Ranjit Chatterjee or Dr. Akhil Taneja. So basically, we are 4 or 5 faculties to cover all those 40, 39 or 40 classes in 2 to 3 months time. And you feel free to ask any question during or after the class. Okay, so if you have any query, you can ask me.